Hi, this is Kumar Madassery. So the question I was asked here is a compelling case with use of IVL technology. Although there are many times when IVL has really helped get a good result, I think looking back, a case that really where it was found to be very instrumental was a patient a year or so ago that also unfortunately has cancer and has had some surgeries, especially in the groins for their cancer treatments. So you got heavily scarred groins and at the same time has had peripheral arterial disease for several years. However, got to the point where they're really struggling with sleeping with rest pain and also claudication that got to the point that they're having trouble during their daily activities. And now this is a patient that has been dealing with cancer and undergoing treatment and has been getting to a good state with their cancer treatment, but now quality of life is significantly impacted by this other problem, which is what I call arterial cancer, PAD. So based on exam, I got a CT angiogram because I was worried about inflow, and on CT, I found that there was a moderate to severe calcified stenosis of the common femoral artery. And so, in these type of patients, typically I'd say, let's have you see a surgeon and maybe you can get a cut down and repair, because I still think that's the best option for most patients if possible. So I sent it to a friendly vascular colleague, and, because of their cancer history, because of the scarred groins, and overall their other issues, we talked about it, and they said, it's a little bit higher risk, more than usual, and especially with all their comorbidities, something that patients started to get really concerned about and wasn't sure if they can tolerate it. And the surgeon was also a little bit on the fence about whether it's a safe idea to proceed. And so, we talked about it. I said, well, we can try endovascular since we have IVL and see if we can at least get them to feel better and know that this is going to be something that, if needed down the road, can really be more aggressive with. And so went ahead and went after this percutaneously. And, often in the past when we treat the common femoral in those rare scenarios where you have to, you use high pressure balloons or other balloons and you can't get a great caliber expansion. Sometimes you get aggressive with other approaches, and then you run the risk of perforations or severe dissections, and you don't want to. And some people put scaffolds there. There's more data looking into this, especially in Europe. But until we have more, it's still not probably the best idea unless you feel you have a good experience with it and it's working well. Also, respecting that profunda is very important when we're dealing with PAD. So in this case, I decided to put a buddy wire into the profunda to protect it. Went ahead and used the lithotripsy balloon across the common femoral into the proximal SFA, and was very gentle, a little bit more nerve-wracking than other areas in the first time you try it, and then used it and was able to get good expansion at the low pressures that you use with IVL. And then I was able to follow up after angiogram showed no major perforation or dissection or significant. Used a drug-coated balloon and was happy with the result, but more importantly, in following the patient within 2 weeks and also for a few months, at least up to a year, patient was doing remarkably better. We did have conversations that this isn't a long-term definitive treatment, but it did provide the patient significant relief in what they're dealing with their life, to be able to do their activities, to get some sleep, and to move on. And we talked about, if it comes back, we can have that rediscussion. And since it did help her, we can do it again or still reconsider surgery. But having this tool really helped me feel better about taking this on and not putting this patient into a potential worse cycle and getting a quick, easy result that doesn't take much effort compared to everything else we do nowadays. So I think, to me, that's a very compelling case, because these patients are not just often dealing with PAD. They have so many other disease states going on that whatever we can do to quickly and effectively get them up and moving so they can live the rest of their life better, I think that's paramount. So I think, to me, that's probably one of the best scenarios where I was able to employ it. And I see my colleagues and other friends doing it in iliacs and other places to really help them get a better outcome. So that's what I would have to say about that question. Thank you.